Hi, welcome to JACC. I'm Erica Spatz, one of the deputy editors. I'm delighted to welcome Dr. Mike Honigberg, who's an assistant professor at Harvard Medical School and director of Women's Heart Health Program. He specializes in preventive cardiology and women's cardiovascular health and is an associate editor at JACC. Welcome, Mike. Good to see you.
Great to see you, Erica.
Today, we're going to be talking about a commentary that you wrote for our Women's Heart Health issue for February. And this piece is titled Rethinking Cholesterol Management in Women from Short-Term Risk Estimation to Life Course Cardiovascular Health. I loved reading this piece. Mike, I was interested in what motivated you to write this piece. What from your research or clinical practice informed the need for a commentary like this?
Yeah, and thanks so much for the opportunity to sort of share this piece and for this forum. I think the piece was primarily motivated by two things: by what we see in terms of statistics for heart disease in this country and elsewhere, where we've made a lot of gains with respect to cardiovascular events and outcomes, but we see the fastest growth in cardiovascular death, relatively speaking, in young adult and midlife women of all age groups, and sort of, I think, alarming. And then, as a clinician, sort of what I see on the clinical side, which is either patients that I'm caring for in the hospital who have had a first atherosclerotic cardiovascular event, who often have overt dyslipidemia, hypercholesterolemia that wasn't treated prior to their event. And just thinking, like, how could we have prevented this? How could we have done better? So those are sort of the two pieces that. Oh, and then the other piece I almost forgot to mention is that we actually, so with that background, we actually looked a couple of years ago in my own healthcare system. So the Mass General Brigham system, a system that has really championed and promoted the idea that treating and lowering atherogenic lipoproteins to prevent cardiovascular disease is important. This is a system that believes lowering atherogenic lipoproteins is a thing we should do. We looked at how we were doing in younger adults. So young adults, so age 20 to 40, who had severe hypercholesterolemia, defined as an LDL cholesterol greater than or equal to 190. Our guidelines have said for a while now, clear class 1 indication for lipid-lowering therapy in this population. So these were all folks who should have been considered for treatment. We looked at a cohort of these patients and followed them over a median of 8 years, and fewer than half of them were started on any lipid-lowering therapy. And again, like in a system that we think really believes in this stuff. And so that was sort of a wake-up call to me that, like, even here, even in my own institutions, we're not doing a great job at this. And sort of, so why are we not doing a good job at this? And maybe we're thinking about this a little bit wrong. And how can we do better?
Right. It seems like we're very much overlooking this high-risk population and dismissing very high LDL levels. It also, in your piece, you describe cumulative risk or long-term risk of exposure to atherogenic lipoproteins. How should we be thinking about cumulative risk? I mean, typically in clinic, we look at the last lipid profile and plug those numbers into a risk calculator to understand people's risk. What is this cumulative risk? What's the biology behind it? And how is it informing your assessment of people's risk?
Yeah, I think it's a great and it's an important question. The most extreme example that I think is well recognized by cardiologists is genetic familial hypercholesterolemia, where genetically elevated LDL cholesterol and therefore exposure to very high LDL levels from very early in life. And we sort of recognize that this is a situation with very high cumulative lifetime exposure, very high event risk, warrants early aggressive treatment. Like, that's sort of what our guidelines say. But I think even outside of that more extreme example, we have now mounting data that show us that cumulative exposure to a variety of risk factors, including but not limited to LDL cholesterol, but include certainly ApoB-containing lipoproteins from early in life, even from childhood. That cumulative exposure in childhood, adolescence, young adulthood, and early midlife, that cumulative exposure is independently prognostic for future events independent of values in midlife. And there's even further nuance with the earlier that one experiences that exposure to atherogenic lipoproteins, or that sort of area under the LDL curve, if you will, the earlier that that happens, the more that there's a setup for later life disease. And that's consistent with what we understand of the biology of atherosclerosis, that it's a chronic process arising over decades. We know that there's sort of histologic atherosclerosis in the vasculature of young adults, and from autopsy studies of Korean War veterans, among other studies, and that over time these ApoB containing particles penetrate the arterial wall. They become retained and oxidized. It triggers a chronic inflammatory response, and over time this leads to plaque formation, progression, and then when there's a myocardial infarction, plaque rupture and thrombosis is the most common mechanism. And so again, this is a process where there's an opportunity to sort of intervene early. To your question, I'm not aware, maybe you can educate me, I'm not aware of any existing tools that sort of quantify an area under the LDL curve for a clinician sitting in a clinical setting. Wouldn't it be great if we had that? But I think it's a thing that many preventive cardiologists are sort of doing at a gestalt level. They're sort of mentally looking back, like, gee, maybe your LDL hasn't been over 190, going back your entire life, but gee, it's like been in the 170s and 180s for a decade now. So, we're not necessarily at like the hard and fast guideline threshold, but gee, like I'm awfully concerned about your cumulative LDL exposure. So I think it's a thing we're sort of doing in our clinical encounters already to an extent.
Right. I think like you, I'm using a general gestalt of seeing these elevated LDL levels that are abnormal, sometimes also in people whose lifestyle doesn't match what their LDL level is. And I start to scratch my head and say, you know what? It seems like we have something genetic going on here, even if it's not going to be a monogenic mutation that we find in FH. And that sometimes signals that we need to go a little further than lifestyle modifications to potentially intervene. And that brings me to my next question is like, what do we do? We have this impression that the LDL is high for many years. Yet when we plug the numbers into the risk calculator, especially because it's so age driven, we get a low risk. So there's some discordance there. Should we be intervening on these patients with more than just lifestyle modifications, which is generally what I think women, receive, is do more exercise, eat more healthy? Is that enough, or should we be considering statins or even any other lipid lowering therapies?
That's the key question. And I think it's very individualized. It's individualized both in terms of the patient's overall risk factor profile. It's individualized based on the extent of hypercholesterolemia, and it's individualized based on patient preferences. We see patients who, really strong family history, I think, is a common example that I see in my practice of referrals with sort of moderate hypercholesterolemia, sudden cardiac, atherothrombotic cardiac death in a family member. Patient is very motivated to make whatever changes, a clinician thinks would be beneficial for reducing risk. And both on the lifestyle side and on the pharmacotherapy side. And, that's often a patient where, particularly if LDL cholesterol is elevated despite excellent lifestyle measures, as you were alluding to before, that's a very appropriate patient for therapy. There's a lot of benefits to starting early for patients who are interested in being more aggressive. You have the luxury of time to start low and go slow. Try low dose. Make sure that it's well tolerated by a patient. Make adjustments if it's not well tolerated by a patient. And oftentimes in younger patients, the lowest dose of rosuvastatin or atorvastatin can go a really long way, and that's really all you need. But I think there's a lot of shared decision making, particularly when you're considering more sort of earlier preventive pharmacotherapies, because you're talking about really sort of long-term treatment in that case. but there's a subset of patients that I definitely think benefits from that. The other thing I think that's worth just saying out loud to your point about the sort of limitations of risk calculation is that to this point, sort of pre-prevent score, we were really anchored on 10-year risk estimation to guide treatment recommendations. And that's based on the very reasonable premise that we don't want to overtreat people. We don't want to commit people unnecessarily to long-term treatment, but it has real limitations. As you said, it's very dominantly driven by age and sex in the risk calculation. So even overtly high risk patients who any clinician would recognize as high risk, um, often based on things that are not captured in the risk calculators, things like lipoprotein little a status. Now, prevent includes BMI, but all other things, pre-diabetes, other aspects of family history. There are patients we see who are clearly high risk, but the calculator doesn't recognize them as high risk. And so, I think it's just important to acknowledge the limitations of these population-based risk calculator strategies and perform sort of comprehensive risk assessment when we're thinking about these patients.
This is so helpful to talk through these common issues. I want to end on something that is pervasive throughout women's health in general, and also within cardiology, is a concern around the reproductive years and how do we manage that. If I'm a patient who has high cholesterol, I'm interested in being aggressive, I have a family history, I'm informed, I'm aware, and I want to take all measures to help optimize my cardiovascular health, and I'm looking at family planning. What are some of the strategies that you use to counsel or to talk about, some of those concerns related to fetal development or nursing and such?
Yeah, I mean, a critically important question, and I think sort of a really important implementation barrier, particularly in sort of young adult and midlife women. There's this, really based on animal studies that tested super physiologic doses of statins, there's been this concern about teratogenicity for a long time. Um, and so I think, like, so first things first, understanding a patient's reproductive goals. Is the patient actively trying to get pregnant now? Are they looking to imminently become pregnant? Or is pregnancy more of a long-term consideration and they have active, long-acting reversible contraception in place and there's um, no short-term reproductive plans? Really sort of tailoring, treatment recommendations to a patient's short-term goals and make sure you've elicited those goals and are sort of working with the patient. I think um, just to say explicitly something that I think is still not entirely widely recognized, it is safe to use lipid-lowering therapies in reproductive age women. Um, we do not routinely recommend using statins in pregnancy, although, just to say, in 2021, the FDA removed the black box warning sort of indicating teratogenicity from statins on the basis of several lines of evidence, including large human cohort studies of exposure in pregnancy not demonstrating increased risks of congenital malformations, and then data from several, including one large trial of pravastatin for preeclampsia prevention. And while pravastatin, the evidence that pravastatin prevents preeclampsia is, I'd say, quite mixed at this point, there was a pretty clear signal for safety in those trials when started after the first trimester. And so, with those data in hand, FDA said, there are going to be situations, they're not going to be that common, but situations where it's actually reasonable to consider continuing statin therapy in pregnancy. And I think we would really think about that primarily, at least in my practice, in a patient with established clinical atherosclerotic disease, prior myocardial infarction, for example. And then, sort of one rung down would be familial hypercholesterolemia, particularly if there is evidence of subclinical atherosclerosis on imaging. That's a shared decision-making discussion. For most patients, particularly if you've been aggressive early and they've been on treatment, you can feel pretty comfortable withholding treatment for the period of getting pregnant, pregnancy, and breastfeeding. Statin use is not recommended during breastfeeding currently. So the strategy, just to sort of summarize my strategy, it's understand the patient's reproductive goals, treat if it's otherwise appropriate to treat them and they're not imminently about to get pregnant or breastfeeding. If they are planning to get pregnant, discontinue treatment when they start trying to get pregnant, and then restart again at the completion of breastfeeding.
One of the concepts that you've laid out for us during this interview and have demonstrated in your approach to patients is this concept of the life course, and really thinking about how do we mitigate risk in women, being sensitive to different times in their life that where we may be able to cut back, right? And say, let's stop this medication for these next year, 2 years, but mitigate that risk in between, and really thinking about the long-term goals. So I so much value your approach to this topic, your sensitivity to the issues that women face as they're navigating, their own personal health, the baby's health, or how much or little they want to do in prevention, and really thinking about the long term through these different milestones of a woman's life. So thank you for all that you've contributed to this field. Thank you for this really important commentary, and thanks for being part of the JACC community as well.
Thanks so much.